This was the first study to look at the effectiveness of CAR T cells in the second line setting for relapsed refractory aggressive large B-cell lymphoma pertaining to a population of patients who would be poor candidates for autologous transplant. So the reason we wanted to do this study was that we know that CAR T therapy has actually shown durable responses in third line or later relapsed refractory large B-cell lymphoma. And even though these patients in the second line do have a potential curative option such as autologous transplant, not many patients are able to get to that point. And the reason is that they may have poor prognostic features that impair responses to salvage chemotherapy and make the disease chemo-resistant. And if someone has chemo-resistant disease, autologous transplant is not really performed. Or they may be, the patients themselves may be older, frail, have comorbidities, which limit their ability to get high-intensity regimens and transplant for the relapsed refractory disease. So therefore, this is an area of unmet need, and to see if Liso-cel, Lisocabtagene Maraleucel, has effectiveness, and if this can be done in a relatively safe manner, and if it has efficacy in this population, that would fill this unmet need. So that is why this pilot study is performed. So, just to give you a little bit about the schema for the study, bridging therapy was allowed. After undergoing leukapheresis, patients were allowed to undergo bridging therapy, but that PET positive disease was reconfirmed prior to giving lymphodepleting chemotherapy. And so that is an important thing. So every patient who went into this treatment had to have PET positive disease prior to starting. So that is important. Patients who were the histologies which were included were DLBCL, including de novo, as well as transformed from indolent lymphoma. We also included patients with high-grade B-cell lymphoma, including that includes double hit and triple hit, and then follicular lymphoma 3. Patients had to have at least one prior line of therapy. So they all needed one prior line of therapy with at least an anthracycline and a CD20 targeted treatment. So examples would be R-CHOP or R-EPOCH. And then they should have two things. One is they needed to be ineligible for autologous transplant. This had to be deemed ineligible for autologous transplant by the investigator. And they also needed to have at least one of this non-transplant eligibility criteria, which was devised based on expert evidence and some publications which were there in this area as treatment guidelines. So they needed to satisfy both, and those included those transplant non-eligible criteria, which basically says that a patient may be a poor candidate for autologous transplant. They included age of 70 or above, performance status of 2, and some markers of moderate organ dysfunction, mild to moderate organ dysfunctions, such as having a pulmonary function, impaired pulmonary function, such as DLCO of 60% or less, impaired cardiac function with an EF of 40 to 50%, impaired renal function with a creatinine clearance less than 60, but it had to be above 30, and or impaired liver function with AST and ALT 2 to 5 times normal. The patients needed to have at least one of these criteria, in addition to the others which I mentioned. The primary objective of the study was overall response rate. And what we noticed is that the most frequent reason for getting into the study, after meeting the disease-based characteristics, was age of 70 or above, followed by performance status of 2, followed by impaired creatinine clearance. So, in fact, 62% of patients had more than one criteria. So there are 2 or more criteria which made them poor candidates for transplant. So the other thing we actually collected is we looked at this score called HCTCI score. So this is a scoring to understand the depth of comorbidities the level of comorbidities before transplant typically. And when patients have a higher score, higher HCTCI score, they usually end up having poor outcomes after transplant. And that number, which we have, the median HCTCI score in our population of patients who went through this Liso-cel treatment was 3. And in fact, 52% of patients had a score of 3 or above. So what I'm telling you then is that the baseline patient characteristics were included older, frail, comorbidities. And then when we look at the disease-based prognostic factors, there were 52% of patients who had a primary refractory disease. We also had 21% of patients with disease relapse before 1 year. And then there were 31% of patients who had developed lymphoma. So now, not just frailty and age and comorbidities, but also high-risk disease. So that is the population we were treating on this trial, and with that, just wanted to bring up a few other things. That there were patients who had increased bulk. So there were patients with bulky disease which were included. There were patients with height and the age which were included. The median age for patients on the study was 72, and actually 86% of patients had age of 65 or above. So another elderly group of patients. So let's talk a little bit about the safety part first. So investigator assessed treatment emergent adverse events were noted as 86% any grade, and 69% of patients had grade 3 or 4. And within that, cytopenias were actually the commonest grade 3, grade 4. But with any CAR-T study, you want to know the 2 special interest adverse events. One is cytokine release syndrome, or CRS, and the second one is neurologic events. And so in our study, we saw lower incidence of both. And in terms of CRS, the incidence of CRS was 21%, and they were limited to only grade 1 and 2. And then in terms of neurotoxicity, it was low as well, total 10% neurotoxicity, neurologic events, of which, again, there was no grade 4 or 5. So those were the 2 important findings. And then, since there was low incidence of CRS and not really high-grade CRS, the tocilizumab use was also fairly low. And in terms of use of tocilizumab and corticosteroid for CRS, it was only for 10% of patients, a total of 3 patients actually. So those were the sort of the main adverse events. Now moving on to the important discussion about efficacy. The overall response rate, the primary objective of the study, this high overall response rate was 89%, and then the complete response rate was 56%. There were 2 patients who had a partial response who then converted into a complete response with longer follow-up. The median follow-up time is not very high, 5 months, but within that time frame, for patients who had more than 1 time point where response was assessed, when they went into a CR, 10 of the 12 patients had their CR persist. So the Kaplan-Meier estimated probability of continued response at 3 months, 63%, at 6 months, 53%. So that is sort of the summary of the findings on the study. So to conclude, this is the first study which showed which was performed for patients with relapsed or refractory large cell lymphoma in the second-line setting, that is after completion or failure of 1 line of therapy. The patient population just over here is a population of patients who are poor candidates for transplant. So this is not a transplant-eligible population. This is non-transplant eligible. And they also have high amount of comorbidities as assessed by age, grade 3 markers like HCTCI, ECOG performance, moderate or mild to moderate organ dysfunction, and so forth. So in this population of patients, high response rate, high complete response rate, 56% complete response rate, and also low toxicity, low incidence of CRS, neurotoxicity, and low incidence of high-grade events. Most of the high-grade AEs were cytopenias. There was no CRS or neurotoxicity, which were of high grade. In fact, CRS, there was no CRS of grade 3 or above, and no neurotoxicity of grade 4 or above. So with this pattern, we were able to give outpatient monitoring for patients who receive this treatment in 41% of the patients. So because of the risk benefit and the risk profile, even though these patients were otherwise high risk, but because the AE profile was milder, 41% of patients actually were able to get outpatient monitoring after receiving CAR T cells. So this trial is ongoing, and we hope to see more results, more mature results in the future.